why should I not consider this as a painless jaundice initially, and then a complication causing the pain rather than the other way around? Consider it as a painful jaundice.
Yes, sir. So as I mentioned, sir, multiple causes are there. So one I told like there is progression of lesion. One might be there is cholestasis and there may be, sir, hepatomegaly and stretching of the liver capsule. There may
Very
be, sir.
different, no? Pain because of a malignancy, pain because of stretching of a liver capsule is very different. Dalek,
Yes, sir.
no? So the
Yes,
character
sir.
of pain is important to try and sort of tease out. To my mind, once we get to this level, we tend to forget a lot of our undergraduate stuff. So we still need to spend some time trying to understand what is happening. Uh, you know, Try and look at the pain a little better. Look at the characteristics of the pain a little better, its relationship to meals a bit more, and try and see if you can find a reason for the pain. In the history, you're not going to find the reasons of the pain in the examination, very unlikely. So most of your
Yes.
dissection of what is happening in the because of the pain or in relation to the pain is going to happen during the history taking. So I think a little more on the pain that this patient had. Okay. Uh, you told us that he had no significant comorbid conditions. Did he have any episode of fever during this time?
No, sir. Didn't have any fever episode, sir.
Okay. His pale colored stool seems to be in relation or timing chronologically with the pain. Uh, how do you try and explain that? See, he started
Uh,
passing pale colored stools and he also had pain.
uh, yes, sir. That so. One thing, sir, I think here, like after 2 weeks, there may be complete obstruction, and this pain may be some form of some subclinical cholangitis, sir.
Subclinical cholangitis, I can't understand that. Okay. All right. So you see, he's got a continuous dull aching pain. It should very well be because just as you said, stretching of the liver capsule and nothing else. So largely it's a painless jaundice, no, rather than a painful jaundice. See, if you say
Yes, sir.
painful jaundice, then the things that come to my mind are gallstones, uh, CBD
Yes,
stones. Malignancies don't come to my mind. 1 month history, see a pancreas causing pain. It's usually further down the line when the lesion has increased in size to a larger extent. Okay,
yes,
so
sir.
when you say painful jaundice, the causes that come to mind are different from those that come with painless jaundice. Okay, in the absence of any fever, in the absence of any obvious signs of cholangitis, the passing of the pale colored stools 2 weeks after the onset of jaundice obviously signifies that whatever was causing the jaundice has progressed. Okay, it's not something that's uh, a remitting kind of thing. It's something that seems to be progressive. From an
Yes, sir.
incomplete obstruction, he has developed a complete obstruction. So that part I agree with you. Okay, so what are your possibilities based on this history? Painful jaundice, you said, huh?
Uh, yes, sir.
Mhm.
So in painful jaundice, again, sir, I consider here malignancy over benign, sir.
Okay.
So the pain,
But
yes, sir.
the moment you say painful jaundice, the pain is usually associated more with benign conditions rather than. Anyway, okay. All right. So you
Yes, sir.
wish to consider a CA head pancreas. Why do you wish to consider CA head pancreas, as the
Sir,
first possibility?
Uh, sir, in malignancy, the painful jaundice, sir, there is uh, possibilities are see carcinoma head of pancreas, carcinoma GB neck, sir. So in this patient, sir, so there is no prior history of pain and there is no changes of character of pain. So I considering
So between the
this.
4 diagnoses that you have provided us, why do you put 1 CA pancreas, 2 CAGB neck,
Yes, sir.
3 periampsia, and 4 hyalocholangiosia?
Yes, sir.
How do you justify these 4 diagnoses?
Yes, the pain is after the jaundice. So I'm considering here there is progression of the lesion. So I consider as a carcinoma head of pancreas and CAGB second because there is no prior history of pain or there is no changes of character of pain from colicky to continuous type. And I consider periampullary as third, sir. There is no history of cholangitis, sir. So in distal obstructive lesion, there is more chance of cholangitis, sir. So I kept it there. And as hilar cholangiocarcinoma, there is less likely patient to have pain, sir. And most of the time, not always, the jaundice is preceded by pruritus, sir.
You've got me all confused. Either I don't know my surgical obstructive jaundice or you're getting me all confused. Tell me, CHGB neck gives you pain and hyalocholangio doesn't give you pain. It's a dull aching pain. Both conditions will give you dull aching pain. Periampullary carcinoma gives you cholangitis, but CA head pancreas doesn't give you cholangitis. Therefore, you put periampullary carcinoma down below. Hyalocholangiocarcinoma gives you cholangitis. Does it?
So, sorry, sir, can you
So
repeat?
lower end blocks you said give you cholangitis. CA
Yes,
head
sir.
pancreas is complete obstruction, therefore you put it up or right on top. But hyalocholangiocarcinoma, which usually does is not associated with cholangitis, you put right at the bottom. So this is some kind of I can't figure out. See, it's very simple. If you have an incomplete obstruction, it's usually more benign rather than malignant. Malignant
Yes, sir.
obstructions are almost always complete obstructions. So irrespective of whether you have C head pancreas, periampullary carcinoma, carcinoma gallbladder, or hyalocholangiocarcinoma, the likelihood of cholangitis in these conditions, all 4 of them are malignant conditions, is small. Okay.
Okay, sir.
Malignancies are complete obstructions, benign conditions are incomplete obstructions. Okay, clear?
Yes, sir. Yes, sir.
First. Second rule of the game. If you have to give a differential diagnosis in a patient with surgical obstructive jaundice, it's always a good idea to try and figure out whether the upper end is involved or the lower end is involved. If you think it is more likely the lower end is involved, then use that all the lower end possibilities first and then provide the upper end possibilities. Now you're going lower end, upper end, lower end, upper end. So to my mind, you're confused. You're not sure. You're just taking your chances, 50-50 chance. Let me put this, 50-50 chance. Let me put this. Are you going by the incidence? CGB is generally more common in women. 47-year-old male. So, we've got to look at the totality of the information that we have. If you'd given me 1 DD, surgical obstructive jaundice, that'd be good enough. Possible etiology, malignancy, I can't say whether it's upper end or lower end. And hence, I will not venture to make a diagnosis beyond this. That's fine with me at the
Yes,
point
sir.
of the history taking. Okay.
Okay.
But to give me these with no justification for going one way or the other is something that I think is not a great idea. Okay. So always try and think through what you're going to say and try and see how you're going to justify this. I don't see your
Yes.
justification at the moment in any one of these. Okay.
May I
Okay.
interrupt, sir?
Yeah, please go ahead.
Yeah. Azhar,
Good.
what are the
Yes, good
components
morning,
of
sir.
cholangitis that you require for cholangitis?
Yes, sir. There is a Tokyo guideline to diagnose the cholangitis, sir. So one side we have the symptomatology, and second side is the laboratory or imaging parameter. So criteria
Let
A
us go
is
by
So
generic
Azharuddin, at the
first.
moment you are at the
It is clinical.
history.
So
So
tell
it's
clinical.
not investigations, no? And you don't need Tokyo guidelines to tell you what is cholangitis. Without Tokyo
Yes,
guidelines, also you know what is cholangitis.
yes, sir. So
So
patient,
don't always look for a guideline to give you a diagnosis. You didn't quote a guideline to say CA had pancreas, CA GB, periam, CA hyalocholangio. Suddenly for cholangitis, you got Tokyo. Tokyo doesn't come into the picture at this point in time. Anyway, go ahead.
yes, sir. So fever will be there, sir, or second fever or second chills. And second, there will be, sir, jaundice will be there.
How
And
many
third is,
components are required to make a diagnosis of cholangitis?
yes, sir.
Two
For defin
components out of the three is a diagnosis of cholangitis. There is pain, there is jaundice, and it is surgical obstructive jaundice. So why is it not subclinical cholangitis? Clinical cholangitis. Why subclinical? Clinical cholangitis.
yes, sir.
You don't need fever all the time, and fever may be low grade also, and he may not notice.
Possible, sir. Yes, sir.
That is one thing. Second thing, like Sir said, you seem to be biased by knowing the investigations. That's why you have put this list. You have not kept an open, clear mind while trying to dissect out the diagnosis. Patient has painful progressive jaundice and has weight loss, and significant weight loss in 1 month is a distinct impossibility. Significant weight loss means 10 kilos weight loss in 1 month. Has that happened?
No, sir, 5 kgs in 1 month, sir.
5 kgs in 1 month. So that could be just loss of appetite, loss of weight, because he is not able to eat because of itching and because of jaundice. And many people have this belief that in jaundice they shouldn't eat. Indians believe
Yes, sir.
in jaundice you shouldn't eat. You should stay fasting. You should not take yellow stuff. So that itself can account for the weight loss. So if you put that aside, CBD stone in a 47-year-old man still remains a possibility. A stone impacted at the lower end can produce the same symptoms as a periampullary carcinoma.
Yes, sir.
So you have to keep benign possibilities. You can keep Mirizzi, you can keep stone at the lower end of the CBD. All these can cause similar symptoms like a carcinoma, gallbladder neck, hilar cholangiocarcinoma. Mirizzi syndrome can mimic it.
Yes, it can be me.
By totally excluding benign causes, you are saying, I know the diagnosis. We are not saying we will be right. But at this point of time, your thought process should be like this. You should include these possibilities.
Okay, sir. Yes.
Please go ahead.
So in general physical examination, patient is conscious, cooperative, oriented to time, place, and person. His BMI was 24.2 with a weight of 75 kgs. He was moderately built and well nourished. His stunned cooperative oncology group performing score was 0. Breath holding time was 35 seconds, and icterus was present. There is no supraclavicular lymphadenopathy, peripheral edema, and there is no pallor. And hemodynamically, he was stable. And so this is my general physical examination. So going to para-abdominal examination. On inspection, there is scratch mark over the abdomen, scratch mark over the extremities and abdomen, and otherwise no significant finding as per inspection. On palpation, abdomen was soft, non-tender. Liver was palpable 2 centimeter below the costal margin with firm inconsistency with regular surface and firm sharp border. and gallbladder was not palpable, and spleen also was not palpable, and all hernial orifices, external genitalia, no palpable impulse was felt. So on percussion, upper border of liver dullness held at fifth intercostal space in mid clavicular line. Liver span was 16.7 centimeter in right mid clavicular line. Flanks were tympanic. And on auscultation, there is normal bowel sound heard. And on digital rectal examination, there was normal sphincter tone and glove stained with pale colored stool. There was no palpable growth or pelvic deposits. So other systemic examinations remain normal. So in summary, after examination, so I would like to add the examination finding presence of icterus with scratch mark over the abdomen and extremities, and there is GB was not palpable, and on DRE, digital rectal examination, finger gloved with clay color stool.
Okay, so tell me, what is an important finding that you've not mentioned in your summary? In the context of a patient with surgical obstructive jaundice, you mentioned that he had scratch marks, you mentioned that he has jaundice, you mentioned that his gallbladder was not palpable. There's something else that I wish to know before I proceed to ask you what your differential diagnosis is after this.
Hepatomegaly, I didn't mention here. I
Correct.
should have
So I
mentioned.
think it's important to know whether the liver was enlarged or not enlarged. Why is it important? So something that I didn't ask you at the end of the history, but I'm asking you now, could this be a possible medical jaundice? Could this be acute viral hepatitis with a cholestatic phase in the second week, third week of illness? And his weight loss could be because of the severe cholestasis that is happening.
Less likely, sir. Patient doesn't have any prodromal symptoms, and patient doesn't have any high risk behavior. There is no previous history of any blood transfusion, sir.
So what high-risk behavior are you looking for? What are the
Any
common kinds of hepatitis that you normally see in the community? Waterborne.
sir,
Enterically
hepatitis B and C.
Enterically transmitted is more
Enteric
common
transmitted.
there. Yeah. So in
Yes,
the
sir.
community, I'm not just saying a hospital setting. Once he is
Yes,
sick
sir.
and he's in a hospital setting and he's been coming in and out of hospital, obviously the bloodborne infections will come up higher up in the list. But in a person who's sitting in the community, Hep A and Hep E would be more common acute
Yes, sir.
viral hepatitis. And if he has acute viral hepatitis, then one of the things that you want to know at the end of 4 weeks of illness in a patient who has cholestasis is whether his liver is palpable or not. Why else do you want to know whether the liver is palpable or not?
There may be, other than cholestasis, sir, there may be, sir, cholangiotic liver abscess that causing hepatomegaly. Third thing is there may be
See, look at the
metastasis.
clinical context. Do you think this patient could have cholangiotic abscesses?
Not, sir, less likely.
And do cholangiotic abscesses actually cause an enlargement of the liver?
No,
So
sir.
I was looking for something else from you. I was looking for you to tell me that this person could have an underlying chronic liver disease with a shrunken liver, but nothing prevents him from developing a carcinoma or gallstones or anything else. So therefore, if the liver is palpable, then I
Yes, sir.
know that more likely he doesn't have, whatever he has is a more recent condition rather than something underlying. So it's always good to tell us whether you have palpated for the liver or not. In a person with such a short duration of history and has cholestasis, unlikely, but a person who has a slightly longer duration of history, is there anything else that you would like to say is not present?
Metastasis, sir.
I think ascites and pedal edema are something that one would sort of be something important that I would want to say were present or not present in the context of a patient with obstructive jaundice. If a patient has only 4 weeks of jaundice, maybe it's not as important as somebody who has 12 weeks of jaundice. But that's something else that also you would want to contribute to by saying whether the patient has any ascites or any pedal edema. Okay, now tell
Yes, sir.
me, after this examination, why have you not changed the order of your differential diagnosis?
Uh, because sir, here one thing like here GB is not palpable, but distended GB and not palpable GB are not the same, sir. Because patient is having hepatomegaly, so the
You're
distended GB may
overthinking.
not be palpable.
You're overthinking. The gallbladder is not palpable on a clinical examination. You can give me multiple reasons. If I tell you later on that this patient has CA pancreas, you can give me multiple reasons for why the gallbladder was not palpable. But clinically, if I am sitting in the outpatients and I see a patient with obstructive jaundice for 4 weeks and who seems to have a complete obstruction and the gallbladder not palpable, what comes first to your mind?
I will think regarding the distal obstruction, sir.
Gallbladder not palpable, you will think of distal obstruction.
Sorry, sir, I got confused, sir. So I will think
So
about proximal
here, if the
obstruction, sir.
gallbladder is not palpable and you're thinking of a malignancy, the only
Yes, sir.
possibility that would come up, number one on the list,
Proximal,
is a hypercholangiocarcinoma or
hypoproximal obstruction.
calcification.
Yes, sir. Yes, sir.
Okay. In the context of him not having had any previous episode of pain, I would put CAGB second, not first. And both my
Yes,
lower
sir.
distal obstructions would go lower down in the list. So I agree with Dr. Desai when he says that, you preconceived your diagnosis. You either have the information or somebody's told you. If you do this in the exam, if I am the examiner, Dr. Desai is the examiner, we're going to be upset. Okay. This tells us very clearly that you're not thinking through things. You're doing exactly what you know is there, and therefore everything has to be tuned to fit what you know. Okay. So if I tell you that a patient has CA pancreas but no gallbladder palpable, what percentage of patients with a CA pancreas, a distal obstruction, would not have a gallbladder palpable?
Around, sir, 40 to 50% patients, sir.
Half the patients will not have a gallbladder palpable. Is that correct?
I think, sir, around 40%.
So my impression is more like 1/3, 2/3 would have. And therefore, if 1/3 don't have, and 2/3 have, then that becomes a rarer possibility. And therefore, I use something else to justify my findings. So there's nothing wrong in saying that this patient could have a hyalocholangiocarcinoma, could have a carcinoma gallbladder, and say that the possibility of a distal obstruction is less likely because I could not palpate the gallbladder. I'm doing a clinical examination. No?
Yes.
And benign causes assume importance when the gallbladder is not palpable. Courvoisier's law itself says that benign obstruction is possible now. You should think of Medici syndrome, which can mimic hilar cholangiocarcinoma. Gallbladder may not be palpable because the gallbladder is contracted. You can think of a double impacted stone.
Yes.
What are
All
the
right.
other possibilities for non-palpation of gallbladder in surgical obstructive jaundice?
Uh, Sir, as you mentioned, primary CBD stone, sir, and as you mentioned, double impacted stone, sir.
Double impacted will produce gallbladder or it will not produce gallbladder? Will you get mucocele or you will get contraction?
I'll get in double impaction, I'll get mucocele.
Yeah, so you will get a palpable gallbladder.
Palpable gallbladder, yes.
You have to disagree with your examiner when your examiner is saying wrong things. That is one of the slipper methods that is used by examiners. You should have a strong viewpoint, you should be clear of your facts, and you should contradict the examiner if you don't agree with him. Don't be afraid of the
Okay, sir.
examiner.
Okay, so would you like to revise your diagnosis now, differential diagnosis?
Yes, sir. So I consider hilar cholangiocarcinoma first. Second, sir, carcinoma GB neck, and in last, the distal obstructions.
You don't want to consider a benign condition at all?
Benign, sir, less likely, sir. The patient should have
Okay, fine.
some form of pain in before developing jaundice, at least, sir.
All right.
Not necessarily.
Could this be a colorectal cyst with the malignancy?
Yes, sir. Is a possibility, sir.
So
What are
I
the
don't.
what is the triad of choledochal cyst?
There will be, sir, pain, cholangitis, and malignancy, sir.
Palpable mass.
Palpable mass, yes, sir.
There is no
Palpable
palpable
lump.
mass.
Yeah. Okay. Also, in a 47-year-old, I won't venture to make a diagnosis of a colorectal cyst on clinical grounds unless I have very strong reasons to do it. Okay, I'm happy to be surprised once in a while by an ultrasound. Okay. So, or by any other investigation that I may do. But I think it's important for you to think through all these possibilities. So somebody says
Yes, sir.
this could be a possibility. You have thought through it, and you can tell us why you think it's not an important reason, important enough option to be put into the list of differentials. All right. So you don't think this is a benign condition. You think this is a malignant condition. And your
Yes, sir.
primary reasons for thinking that this is a malignant condition is that this is a short duration of history.
Yes, sir. And there is
Okay.
no prior history of pain,
Significant
sir.
weight loss.
Yes, sir. And there is no prior history of any pain, sir. No
Okay.
common colicky pain, and even pain develop after 2 weeks of developing of jaundice.
Okay. And you think that there is complete obstruction because he has colored
Yes, sir.
stools.
Yes, sir.
All right. Complete obstruction are more common in malignant conditions.
Malignant condition,
Okay.
yes, sir.
Okay. All right. So in this context, now how are you going to investigate this patient?
What are the symptoms of a gallstone disease?
Yes, sir. The most common presentation is most asymptomatic, sir. And
You are
second,
contradicting yourself. Just now you said it is not possible because there is no pain. Now you're saying majority are asymptomatic.
sir, I'm considering not only pain, sir, the other features also, complete obstruction, progressiveness. There is no waxing, waning, there is no intermittency, and
Meiji syndrome
clinical.
will produce that. It's a 47-year-old gentleman, long-standing gallstone disease can produce Meiji syndrome. And Meiji syndrome is indistinguishable clinically from hilar cholangiocarcinoma or from a carcinoma of the gallbladder. And being in the north, carcinoma of the gallbladder with a contracted gallbladder with a liver extension of gallbladder carcinoma, you should keep in mind gallbladder of the neck, gallbladder carcinoma of the neck will again produce a mucocele and will produce a palpable gallbladder.
Yes.
Okay. So what is the next course of action that you would wish to take?
So I would like to investigate this patient with some blood investigation, sir. And yes, sir. So I'll do complete hemogram, liver function test, kidney function test, coagulation profile, and patient viral marker, sir. And as I'm suspecting malignancy, so I would like to do tumor
Why
marker
do you want
also,
to do viral
CA99.
markers on a patient whom you're suspecting malignancy?
One here less for diagnostic purpose, more for further invasive or semi-invasive procedure. And as patient having palpable liver,
So in all
so there,
patients in whom you do, sorry, sir, I'm
yes,
sorry, I'm interrupting you. But in all patients in whom you do an invasive procedure, you would do uh, uh, viral markers.
actually, sir, we are doing here, sir.
So if you're doing a
All
cholecystectomy, you would do Hep B, Hep C status, and you would do HIV. Would you counsel the
yes,
patient
sir.
before you do
Yes, sir.
these?
Yes,
Would
sir.
you counsel the patient?
Yes, sir. Before doing HIV marker, sir, I will counsel, sir, not for hepatitis B and C, sir.
Why? You'd counsel them whenever you do any test. But I don't see the logic of doing Hep B, Hep C in everybody. And I don't see the logic of doing Hep B, Hep C in a patient in whom you're considering a malignancy here, not for diagnostic purposes in any case. And even if I was to do an intervention, you see, why do you do Hep B, Hep C, HIV? If you follow universal precautions.
Yes, sir.
So Tokyo guidelines
That's
is
all.
fine, but all other guidelines you wish to ignore.
Yes, sir. If I am following the universal precaution for all, then
So why don't you? If
that's
you're following the universal precautions, why should you do Hep B, Hep C, and HIV?
uh,
I know a lot of people do it, but then in the exam, if you say this, then you've got to justify.
yes, sir. I'll take universal precaution, but I may get prick, sir. So prick
So,
What
can
are
happen.
universal precautions?
so what is the likelihood of your getting a prick?
Uh, Less than 1%, sir.
So that is the problem. We do whatever we feel like doing, and we then try and justify it. Anyway, Dr. Desai asked you a question. Let's try and answer his question first.
What are universal precautions in relation to a surgical patient?
Yes, sir. So I should cover with the our mucosal surface like eyes, sir, and mouth, lip will be covered by mask, and any
What is protective gear when it comes to universal precautions? What protective gear will you wear?
I have to read it, sir, to
Okay.
know it completely. Yes, sir.
Okay. Okay.
Good. So therefore, it's extremely important not to say something when if you're unsure of something, don't say it.
Yes,
Okay.
yes,
So you've said universal precautions. You must know what universal precautions are. And as a surgeon, you must absolutely know day in and day out you should be using these universal precautions.
yes, sir.
So how can you say you don't know them? Anyway, all right. So what are we going to do to make a diagnosis? Now let's be a little more focused. we have only limited time, so we must try and get a little focused and see what is available to us, and let's try and get to a diagnosis.
So,
So let's try and make a diagnosis first.
so should I go to investigation part, sir?
And I want to know from you how are you going to make a diagnosis in this case?
Yes, sir.
There's
So,
somebody whose mic is on and has some background noise. Could you please shut off your mic? Thank you.
yes, sir. So I would like to do, sir, liver function test, sir, and complete hemogram, coagulation profile of the patient.
Make a diagnosis. How is complete hemogram going to help you? My specific
What is that?
question was make a
Yes, sir.
diagnosis. Okay.
Yes, sir. So
You can hear
liver
me, no? You
function.
can hear me clearly.
Yes, sir.
I
Yeah,
just saw a
not, sir.
chat saying somebody could not make out my voice. I hope
No,
I'm
sir. I will
clear.
hear, sir. I will able to hear, sir. So, liver function test I'll do, sir, and
Okay.
then tumor
And
marker
what are you
I'll do.
looking at liver function tests, and how is that going to help you make a diagnosis?
Yes, sir. First, I'll establish that it is a obstructive pattern of jaundice, and yes, sir. And
Okay. So how do you establish that on liver function? Tell me, no?
yes, sir. The direct component will be more than 50% of total bilirubin, and with raised alkaline phosphatase and raised gamma glutamine transpeptidase, sir. And there may be transaminitis, mild form of transaminitis may be present, but for obstructive per se, so ALP-GGT will be elevated with direct bilirubin of more than 15% of total
Can you
bilirubin.
make out whether it's a benign or a malignant condition based on the liver function test?
In malignant jaundice, sir, the
Are you
bilirubin
aware of
level
some
will be,
studies done many years ago when people looked at bilirubin levels, alkaline phosphatase levels, AST, ALT levels, and said, this pattern is more likely to be malignant and this pattern is more likely to be benign. You can't be
so in
100%
malignant,
sure. Obviously, you can't be absolutely sure, but you can. Are you aware of any
yes,
studies? No.
no,
Yes,
sir.
you are. No, you're not?
No, sir, I'm not aware, sir.
Okay, all right. So there are a few studies which suggested the bilirubin levels above 12, or some others said above 15, and some people said alkaline phosphatase levels more than 5 times normal are more likely to be associated with malignant conditions rather than with benign conditions. But this was just proportions that they were looking for, and they were looking at large numbers of patients, under 200, 300 patients in whom they found this. So if you have very deep jaundice, more likely to be malignant. Can't be absolutely sure, but more likely to be. A higher alkaline phosphatase, more likely to be malignant. It stems from
Okay.
it being more often a complete obstruction. All right. So
Yes.
obstructive jaundice, incomplete, complete, incomplete cholangitis more common, complete higher bilirubin levels more common. Okay.
Yes,
So
sir.
that's how the relationship goes. Okay. All right. So you want to do liver function test. What else do you want to do?
I'll do, sir, ultrasound abdomen, sir.
Okay. And what do you want to
Show us
look
the
for on the
investigations.
Sorry, sir.
Show us the investigations.
Yes, sir. So this is the complete hemogram showing, sir, patient having normal hemoglobin with normal leukocyte count, with normal neutrophil, with normal platelet set. So complete hemogram showing almost normal, sir. My next investigation is kidney function test. Here, sir, urea creatinine and serum electrolyte also normal. So here we coming to the liver function test. So here a patient is having obstructive pattern of hyperbilirubinemia with transaminitis with hypoalbuminemia.
What is the implication of transaminitis in a case of obstructive jaundice?
Yes, sir. So it in cholangitis or in some subclinical cholangitis, there may be transaminitis, and sometimes without cholangitis also in acute early phases of cholestasis, without cholangitis, patient might have transaminitis also.
Okay, so in this case, what do you think it is?
In this case, sir, I will consider, sir, some form of cholangitis patient is having, sir.
And leukocyte count in neutrophils was 60%. What is the absolute neutrophil count?
It will be around.
I can see only neutrophil and lymphocytes. Other components I can't see. So I can't tell you. But percentages are not enough. Total leukocyte count is 7,000. Of that, 61%
Yes,
are neutrophils. Is that normal?
sir. Yes, sir, normal, sir.
Okay.
Should I go to next investigation, sir?
So tell us,
Anything
what do
about
you
the
think of
albumin?
this?
Patient is having, sir, hypoalbuminemia, sir.
What is the cause for hyperalbuminemia in acute jaundice?
One thing is, sir, as patient having some inflammation, so it is acute phase 14, so there may be hypoalbuminemia, number one. Number two, patient will have poor oral intake, nutritional per se, so that also be a possibility, sir.
What about synthetic function? Is it a reflection of synthetic function? You have hepatomegaly, you have jaundice. Could it be a reflection of synthetic function?
Yes, sir. It gives the synthetic function over the last 2 to 3 weeks, sir.
So, what possibilities would you think of when synthetic function is impaired? What is the clotting coagulation profile? Check that.
Sir, coagulation profile is normal, sir.
Okay. Was any correction given for coagulation profile before doing the test?
No, sir. This test on presentation, sir, on admission. Yes.
Okay. So the only issue is that the patient has hypoalbuminemia. So acute
Yes, sir.
reaction I accept. What about synthetic function?
Yes, sir. Synthetic function also a possibilities, but things is here coagulation profile is quite normal. Coagulation profile is normal, and patient having obstructive pattern of jaundice, in spite of that, coagulation profile is normal. So I give less for these things, sir. That patient having some synthetic dysfunctions,
Okay.
and patient transaminitis also is not that much high. Yes.
What is the normal
So
level
with
of
synthetic
transaminitis
function,
in your lab?
Sorry, sir. Normal.
It's 25 to 30, isn't it?
In our lab, it is, sir, 40, sir.
Yeah, so it is significantly raised. It's
Yes, sir.
almost 4 times normal.
Yes, sir.
Yeah, please proceed.
So our viral marker were negative, sir.
could he have an
So
underlying chronic liver disease which is causing his low albumin? You see, I'm surprised to see that albumin of 2.4. I will definitely do a repeat value and check on it. But if it is persistently low in a patient who has only a 4-week history of surgical jaundice, I would certainly want to rule out a reason for the liver to be abnormal prior to his illness. 4 weeks is too short a time for a person to have such a drastic fall in his albumin. What is the half-life
yes,
of
sir.
albumin?
Sir, 2 to 3 weeks. On average, it is like 16 to 18 days.
Yeah, 3 weeks is what I remember. I may be slightly off the mark, maybe 2.5 weeks or something, but 3 weeks is what I remember. So three
Yes, sir.
weeks to have an albumin of 2.4 for an illness which is 4 weeks in duration is something which sort of makes me uncomfortable. I need to find a reason for this low albumin. He could be losing albumin elsewhere, but he doesn't have diabetes long-standing, so that's another place where they tend to lose albumin. He hasn't lost albumin there either, I presume, unless he has some other long-standing kidney disease, which we haven't picked up as yet. He's not a hypertensive, so that's another condition that gets ruled out. So considering all that, I am just a little uncomfortable with that albumin of 2.4 in a patient who has only 4 weeks and does not have significant clinical cholangitis. He has obviously some amount of subclinical cholangitis happening because
Yes.
the ST-ALTs are more than an acceptable level for a patient with obstructive jaundice. 3 to 4 times is what one would, sort of 4 times is kind
Yes,
of
sir.
upper limit. 3 times is what one would see. So I would expect that he has some low-grade cholangitis as well. But it also makes me wonder whether he has any other
Chronic
hepatitic
liver.
process which is happening, which is causing his raised transaminases and the low albumin. His synthetic function seems to be reasonably okay in the sense that his
Yes.
coagulation profile is fine, and therefore I do need to find out a reason for his albumin to be affected, something that's long-standing rather than in the immediate past.
Another
Okay,
issue
let's
Yes.
go on.
you haven't considered biliary strictures, a differential diagnosis of biliary strictures.
Hmm.
Would this be sclerosing cholangitis?
Uh, May be possible, but again, sir, the sclerosing cholangitic presentation, it won't present with a jaundice. Again, it will have some form of anorexia, generalized weakness. IgG for cholangiopathy may be a possible I can consider, but sir, primary sclerosing cholangitis less likely, sir,
See,
in
the
this case.
rarest condition is what you wish to consider first. You don't want to consider gallstones. You don't want to consider CBD stones. You don't want to consider colorectal cysts. You don't want to consider primary sclerosis. You want to consider IgG4 disease. Out of all these, it's the rarest. But everybody's talking about IgG4 disease, so therefore you want to talk about IgG4 disease. Okay. All right, let's go on. So we've done liver function tests, we've seen the hemogram. What else are you showing us? Coagulation profile you show us. So this
Yes, sir.
PTINR is fine.
Yes, sir. So viral serology is negative for this patient.
As
Tumor
expected.
mark, yes, sir. Tumor marker CA99 is within normal limit.
Would you
I
do
would,
CA99 in the case of severely obstructive jaundice?
Uh,
Do you
Preferably,
expect it to be normal?
no, sir.
Why did you do it?
Because, sir, in some studies showed that we can get corrected value of CA99 in obstructive jaundice, sir.
Mhm.
So is this the corrected value?
No, sir. This is the real value of
I am not
CA99.
aware of any correction for jaundice. I only know that if it's above 300, then it assumes significance. If it is lower than that, it has no significance, even if it is raised in obstructive jaundice. So in obstructive jaundice, first tumor marker, you say CA99, you automatically land in trouble. Why not CEA?
Yes, sir. CA also I should do, sir.
Have you done it?
Uh, could not- It was also within normal limits, sir. Tumor marker were not raised.
Okay. So, with these tumor markers not being raised, what possibilities come to mind now? What happens to your differential diagnosis?
Uh, benign etiology can consider, sir, but again, this is not the 100% sensitive, uh, so I can't preclude the malignant etiology, sir.
Okay, let's do an ultrasound and see what the ultrasound shows us.
Yes. So his chest X-ray was normal, sir. Ultrasound abdomen showing liver inlet 16.5 centimeter with a normal parenchymal echo pattern with gross biliver intrahepatic biliary radical dilatation with common bile duct dilated and it was 15 millimeter and gallbladder was distended with normal wall thickness with a few slurs present within it. Pancreas was not visualized due to bowel gas and there is no free fluid abdomen.
So does this help you?
Yes, sir.
Okay. How?
First thing, as patient having hepatomegaly, so normal parenchymal echo pattern, so patient is less likely having some chronic hepatitis. And second, is it? Second thing is patient gallbladder is distended and with normal wall thickness. So with the CBD of 15 millimeters, so distal, I will consider distal obstruction and carcinoma gallbladder is less likely, sir.
Why? Carcinoma of the neck of the gallbladder is still a possibility.
Yes, sir. But here mentioned as CBD is dilated, so carcinoma neck gallbladder CBD is less likely to be dilated, sir.
You will be surprised, lower end lymph node obstruction can cause dilatation of the CBD. And periduodenal and pericholedochal lymph nodes are enlarged in carcinoma gallbladder of the neck.
Yes, sir. That is also a possibility, sir. See,
So just
but
because CBD is dilated, you cannot exclude carcinoma gallbladder. Especially since
yes,
pancreas
sir.
is not visualized due to bowel gas. Lymph nodes will be present in the head of the pancreas. They obstruct the intrapancreatic CBD and they can cause dilatation. And you are not able to see that region, so you cannot exclude it.
Yes, sir.
Yeah, next investigation.
So what do you want to do next?
Next, I would like to do, sir, triple phase CT scan, sir. So I have to change my screen, sir, to share the CT scan, sir.
Okay.
Are you able to see, sir?
Yes.
Yes, sir. So I'd like to do triple phase contrast CT scan. So this is the axial section of non-contrast CT scan is from of abdomen is showing there is gross bilevel intrahepatic biliary radical dilatation with distended GB is present. I can make out also the dilated uh, common bile duct, sir. And other than that, main pancreatic duct also is dilated, and there is no ascites, sir. No, no ascites, and no any. Yes, sir. This much only, sir. And in lung window, there is no obvious any calcified nodule, or there is no any pleural effusion, sir. Should I move to
Should you do a
next?
chest X-ray in a patient with malignant surgical obstructive jaundice?
Yes, sir. I did it, sir.
Why? What is the requirement? You are
Uh,
anyway going to
First,
do a HRCT of the chest.
if there is
Ultrasound has shown IHBRD. Ultrasound has shown distended gallbladder. Ultrasound
yes,
has
sir.
shown distal CBD is dilated. So why would you do a chest X-ray? Why can't you just go for a straight off CT chest?
In sometimes we can get a clue about the lung mets, sir, lung or lung pleural based nodule, large nodule.
What is the sensitivity for lung mets? What is the sensitivity for pleural nodules?
Uh, it is less only, exact value I don't know, sir. And
So it's a wasted investigation. If you're anyway planning to do a CT chest, it's a wasted investigation. The only situation is where you get cannonball metastasis. You can exclude doing a CT chest later if you have cannonball metastasis. But in obstructive jaundice, malignancies of obstructive jaundice, cannonball metastases are distinctly there.
yes,
So
sir.
chest X-ray is unnecessary. Unnecessary exposure to radiation, unnecessary expenditure and time.
Yes, sir. But for pre-anesthetic checkup per se, not for diagnostic, for PSC per se, we have to do, sir.
CT chest and CT scanogram is adequate. A HRCT chest will tell them more
Yes, sir.
information than a chest X-ray.
Yes, sir. Sometimes they would like to know the position of the tracheal deviation.
That can be
In,
seen on a CT chest.
yes, sir. Okay, sir.
So my advice to you is that if you feel very strongly about something and somebody is telling you that this is not the right thing, then it's much better to step back. In exam, don't go this route of trying to
Yes,
justify something. I call this digging your grave and lying down it and then covering yourself in your grave. So here's good reasons for not doing a chest X-ray, and you're still trying to justify them. Tracheal shift you won't see on a CT, you'll see on an X-ray. I can understand you're justifying that I will not do a CT of the chest, I'll do only a chest X-ray. That I can understand. But if you've already had a chest X-ray done, you can't justify doing a CT scan of the chest. If doing a CT scan of the chest, you can't justify a chest X-ray being done. It's not possible, no? It's much better to say sorry,
yes, sir. Sorry,
withdraw.
sir.
No?
Yes, sir. Sorry, sorry, sir. Yes.
Yeah, you can't justify by going on and on trying to find a reason for it. When you know you have no justification, does it help you? Okay. We passed 10 o'clock. I need to leave. Dr. Desai, maybe you want to continue?
10 minutes. Another 10 minutes.
Yeah. So I'll leave then. Please excuse me. Huh?
Yes, sir. Thank you very much, sir.
Okay. Okay.
Thank you, sir.
Thank
Thank
you.
you so much, sir.
Yeah, go on, describe the CT.
So
Yes, sir.
after
So
city
I'll
finding, we can also include sir. Na?
should I go to next phase, sir?
Yeah, please. Show the
Yes.
arterial phase.
Yes, sir. So this is the arterial phase axial section. So in arterial phase, I would like to assess the vascular anatomy and any arterial enhancing lesion in the pancreas or liver, sir. So here we can see the celiac axis origin with normal course of common hepatic artery, and right hepatic artery is coursing in retrocolloidal manner, sir.
Pancreas.
In pancreas, there is no obvious arterial enhancing lesion, sir.
Okay, so
And
what does that mean? No arterial enhancing lesion.
yes, sir. So there is no neuroendocrine kind of tumor is not there, sir.
Okay. What about the more obvious? Your differential diagnosis, your CA head of the pancreas. Is it there?
Other than NAT, so to figure out other lesion, I should go to portal phase. Other than NAT, I could make out anything else.
Okay. You're incorrect because in arterial phase, you will get a hypodense lesion in the head of the pancreas. If it is CA head of the pancreas.
Uh, yes, sir. This phase is not in pancreatic phase, sir. This is early arterial phase.
Okay.
Sorry, delayed arterial phase, yes, sir. So, yes, sir. Actually, when there is possibility of pancreatic lesion, I should go for CT pancreatic protocol, but which is not done here, sir.
Okay.
So I would like to go to portal phase, sir.
Okay.
So axial section of portal phase is showing normal attenuation of the liver parenchyma with bilevel gross intrahepatic biliary tract dilatation with distended GB, and there is dilated common hepatic duct and dilated CBD with abrupt cutup at the level of head of pancreas with there is dilatation of the MPD. Yes, sir. And lesion per se, I can see a hypodense lesion in the head of pancreas, sir,
Can it be
which
chronic
is
pancreatitis?
less likely, sir.
Pancreatic duct is grossly dilated.
Yes, sir. But the pancreatic parenchymal lobulation is oil maintained, and there may be pancreatitis, chronic pancreatitis without calcification, but uh, most of the time we see clinical practice, we see the calcification also, sir.
Okay.
Yes, sir. And the lesion is, sir, a hypodense lesion in the head of pancreas here.
Where
This
exactly?
lesion,
Show me.
sir,
All of
here,
it is
sir.
looking very dirty. Did the patient have an episode of acute pancreatitis? Was an
No, sir.
ERCP done before this CT?
No, sir, not done, sir.
There are signs of inflammation in the peritoneum.
Yes, so throughout the abdomen, some kind of fat standing is thing, but
Yeah.
maybe yes, sir.
Okay. Go on.
Yes, sir.
Go to the
So
report.
should I move to the report, sir?
Yeah.
Okay. Sir, a ill-defined iso2 hypodense heterogeneous enhancing lesion with size of 3.4 cross 3.2 and 3.5 centimeters seen in the head of pancreas with multiple subcentimetric to enlarged heterogeneously enhancing periportal, peripancreatic, and retroperitoneal lymph node with largest left para-aortic station, sir. And with proximal biliary dilatation, GB was distended, although there is some hypodense thickening of gallbladder is also seen. On USG correlation, there is irregular wall thickening with no significant increased vascularity. And as per tumor relation with the surrounding vascular structure, SMB is partial encasement of the supramesenteric vein with area of contact of 180 degree without any contour irregularity or thrombus. And there is nothing mentioned about the SMA relation with the tumor mass. And there is in liver or there is no uh, feature suggestive of metastasis. And in lung also there is no metastatic nodule or any pleural based nodule, sir.
Okay. Go on.
Yes.
Next investigation. What did you do?
Yes, sir. So
Rajendra
as
sir, we can wind up the session, sir.
Yeah,
We can-
last investigation and then we'll wind up.
Yes, sir.
yes, sir. So here it is. You can
No,
see
next
that.
investigation.
Yes, sir. Next, sir. EVS was done, sir. EVS, EVS and fine needle biopsy was done. So in EVS, that extra thing other than CT scan, what we got here, same SMB and portal vein involvement was there more than 180 degree, and here SMA was involved by the
Less
tumor
than 180 degree or more than 180?
less than 180 degree, sir.
Mm.
Less than 180 degree involvement is there, sir, with the same finding of the lymph node, but here we can't see the para-aortic lymph node, sir. So yes, sir.
So FNAC
So
should what?
FNAC was done from the tumor mass, sir.
And what did it show?
It was suggestive of, sir, adenocarcinoma, moderately differentiated, sir.
Okay. We can discuss treatment at another time.
Yes, sir. Okay, sir.
We should, next session, we should have a surgical obstructive jaundice and we'll jump straight to the treatment. We'll discuss the treatment of surgical obstructive jaundice.
Yes,
Yes,
sir.
sir.
In next
Plan, sir.
presentation.
Yes.
Yeah, okay.
Okay, sir. Thank you,
Okay.
sir.
Okay. Okay. Thank you, sir.